Guys ready?
Go.
Happy lunchtime. Welcome to our lunchtime webinar series presented today, uh, courtesy of MedChi, the Maryland State Medical Association. Today's topic, the perfect storm, balancing medical AI innovation with the reality of 2026 cyber threats. I want to introduce myself. I'm Dr. Eric Wargotz. I'm president of MedChi. With us behind the scenes is our CEO, Mr. Gene Ransom, who's helping assist us behind the scenes. And I want to move on to introduce our expert panel because I know that's who you're waiting for. And I know you're waiting with bated breath. I'm pumped. I can't wait to bring them on and get going. But before that, a little about MedChi. MedChi is, like I said, the Maryland State Medical Association. We are your advocate, your resource, your profession. MedChi's mission is to serve as Maryland's foremost advocate and resource for physicians, patients, and the public health. So thank you all for joining us. Without further ado, let me introduce our expert panel. And I'll tell you, it's a real treat to have these two ladies, these two physicians with us today because there's such busy schedules. I'm lucky we could get them booked. First, in no particular order, there's two of them. We have Dr. Padmini Ranasinghe, MD, MPH. She's an assistant professor of medicine at Johns Hopkins School of Medicine. She completed a combined residency in internal medicine and preventive medicine, along with a master's of public health at the Yale School of Public Health. At Johns Hopkins, she plays a multifaceted role as a clinician, educator, and researcher. Her research interests are broad and interdisciplinary, spanning physician wellness, disaster medicine, chronic disease prevention, health informatics, artificial intelligence in healthcare, and value care-based models. At the AMA, she serves in a critical leadership role as chair of Council on Science and Public Health. Congratulations, that's wonderful. She is a member of the AMA's Digital Health, AI, and Informatics Task Force. And you wondered why we invited her here today, right? And Maryland, she's also a past president, immediate past president of Maryland State of MedChi, and also serves as a representative to the state AI implementation work group, governor appointed, and is involved in continuously organizing AI-related CME courses for our members. I want you all to say hello to Dr. Ranasinghe, and I'm sure she'll have a lot of interesting and fascinating knowledge to share with us today. Our second panelist is Dr. Renee Bovelle. And again, thanks for both of you for cleaning up your schedule, as I call it, and fitting us in. Dr. Bovelle is the owner and medical director of Advanced Eye Care Medical Center, also known as an Envision Eye and Laser. She's a board certified ophthalmologist, was trained at Wesley College, UCLA School of Medicine, and Yale University, and the LSU Eye Center. She was pleased to be named a Washington Top Doctor and Castle Connolly Top Doctor by her peers. Additionally, Dr. Bovelle received a master's in cybersecurity strategy. Let me say that again. Here's a physician who worked hard, received a master's in cybersecurity strategy and information management from George Washington University, and focused on policies and practices that protect critical information with particular attention to the healthcare field. Did I say that? With particular attention to the healthcare field. She has academic appointments at Howard University Hospital, Ross University School of Medicine, and the University of Maryland Capital Region Medical Center. She has been privileged to educate medical students, residents, and physicians locally and during national conferences on broad arrays of issues in ophthalmology. She authored the first MedChi approved continuing education course on cybersecurity for physicians way back when, a few years ago, and continues this work for both national and regional medical organizations. She, in certain articles and presentation topics, which we will hear a little bit today, not in too much depth, but we'll hear a blockchain, artificial intelligence, ransomware, HIPAA policy and strategy, healthcare cybersecurity issues, and quantum computing. Dr. Bovelle holds leadership positions both locally and nationally in ophthalmologic and other medical associations. Currently, she's a board member of several organizations, including the Maryland Society of Eye Physicians and Surgeons, MedChi, Maryland, and is a MedChi AMA delegate. Dr. Bovelle is also president of the Prince George's Medical Society of Prince George's County, Maryland. I want you all just to think a warm welcome for Dr. Bovelle. So, doctors, let's move on. Get right into it, okay? We're going to talk about the rise of shadow AI. That's the concern. So many clinicians are using non-sanctioned AI tools to manage burnout, bypassing institutional security and thus increasing risk. Dr. Bovelle, could you address that for us? And what exactly is meant by non-sanctioned AI tools, and how is that related to the other topics in this statement? Dr. Bovelle?
She's muted.
She's muted. Okay, well, we'll get her unmuted. How's that? In the
Okay,
meantime,
there we go. Can you
yeah,
hear me
are
now?
you there?
Yes,
Okay,
I am. Thank you so much.
sure.
As you mentioned, we are overwhelmed, overburdened. So we tried to find fixes, and AI has provided some of those fixes, but sometimes we just pick things off the internet, or a friend says to use this, I use that, ChatGPT, many others. So shadow AI refers to the unauthorized use of AI tools. They're unauthorized. They haven't been properly vetted. They don't have IT approval or security oversight. And that's for whether you're a independent solo physician or you work in a large hospital system. The reason why this is a problem is because it can have significant risks, such as data leakage, regulatory noncompliance, security breaches, especially. And employees may put insensitive patient information into these unvetted tools. For example, putting patient information into ChatGPT to generate prior authorization letters, or using an unvetted AI to generate SOAP notes. So shadow AI introduces risk, not just because of the tools that are being used, but because there's no formal oversight. It creates blind spots where sensitive data can be leaked or sometimes even be used to train threat actor AI models. So governance now is no longer optional. Additionally, your entire system can be put at risk for a cyber attack. And why is this important? Because patient data can be exfiltrated. And we need to care about this not only because of financial risks, but we are doctors and we are a prime target for cyber criminals. Why? Because our information has bountiful information that these threat actors want. Think of all the billing information. Think of all the demographic information to create another identity or even worse. Several years ago, Vanderbilt University conducted a study, and it suggests that mortality rates at hospitals rise after a data breach. This can result in over 2,100 deaths per year. Imagine that you don't have access to EKGs, or that EKG material is not vetted. Suppose it's been altered. You can't determine. Someone comes in. Is it changed? Is it not? Same for MRIs, other information. So if you don't have the proper information or even access, can't even get the information, you can see how that can result in increased morbidity and mortality.
Well, very good, Dr. Bell. Well, look, it's interesting because before we get to Dr. Padmini's response, I just want to point out, I think all of us can recognize that, particularly in this year, really 2026, the intersection of healthcare AI and cybersecurity has shifted from theoretical risk to a critical patient safety issue. And I think that's the important point that you're making. And Dr. Ranasinghe, would you like to chime in here?
Yeah. First of all, thank you so much for inviting us. It's great to be here with our MedChi family and Dr. Wargotz. I want to applaud for you doing this lunch and learn for our doctors and members. It's really great. And then I think Dr. Bovelle said everything that as a clinician we could hear, and then also extra for a cybersecurity standpoint. I'm just talking as a clinician here. So when we talk about clinical practice today, we all feel many forces are pushing us, right, at once. It's very hard to sustain a private or small group practices and also health systems, I think. At the same time, we all know new AI tools are appearing almost daily, maybe more than one daily, with a lot of promises, with everything from documentation and prior authorization to patient communication. So the tools are appearing really high velocity. So when the practices are going through extraordinary difficult time with high rates of burnout, and doctors have interest or understandably wanted to explore AI tools to help them. And then they may not be formally sanctioned because there's no way to sanction some of them. And then just to survive. So on the other hand, if you work in a large system like Johns Hopkins, there's a clear guardrails, oversight, and system in place, and they have a good governing on AI tool. So in that sense, in some ways we are protected, but go through like a layers of like a guardrails on and evaluations. But if you don't have that kind of infrastructure or visibility, it's really hard to know where to start and what to choose. At the same time, we all recognize that putting personal health information or complex clinical scenarios into this consumer tool, if you will, can create serious privacy, data security, and accountability risks. And then at the end of the day, doctors and practitioners are becoming responsible. So we have to be extra careful, and that's what I would say as a clinician.
So the question becomes, what are the solutions? And so we're going to move on to that. And it's really a privacy paradox. So to solve the privacy paradox, some 2026, some current systems are using synthetic data. They're statistically identical but fake data sets as training models without compromising real patient data, sensitive data, the personal data. The concept of creating AI safe zones where physicians can experiment with approved secure tools. So, Dr. Ranasinghe, if you could just pivot into this as a possible solution, this is what seems to be being talked about by many in the healthcare field. And how do we envision that really works? I've known some physicians who have played around with this. They find it awkward, and they're not finding it very practical in their busy day, but it makes some sense in terms of a safety. But at some point you transition into live data using the most secure encrypted processes that you can. So let's start off with Dr. Ranasinghe.
Yeah, so we all know we don't need to be computer scientists. The essence of this AI tool is having good data. It says garbage in, garbage out, right? If you have good data set, you have good output. And then the model is only as good as the clinical data it sees. But as you know, it put us right in the middle of this privacy paradox. We need rich real-world information to build this useful tool. Yet, we are ethically and legally obligated to protect our patient PHI. So then one approach, as Dr. Wargotz mentioned, many health system and industry actually are using, it started recently, 2025, now it's 26, it's called synthetic data. What that means is they create this statistically realistic but fake data set that mirror patterns in the real world EHR without being traceable to any individual patient. This allows our data scientists and other computer scientists to train, test the models, and allow clinicians to use without exposing that actual risk. But what I'm a little bit excited about is this pairing this with, I think, like a AI safe zones. It is generally AI safe zones. What we have right now is secure, institutional, usually approved environment where a physician can experiment with these kind of tools and try out prompts to see how these systems behave in de-identified synthetic setting. So the goal of these kind of a data set is to give room to learn and innovate while keeping our patients' data and our own licenses and practices, out of this risk. For example, I'm going to give an example of that. So we'll see, imagine Johns Hopkins, so any hospital sets up a secure web portal behind their firewall. So you have to log into your institution credentials and VPNs. And inside that space, you can open an AI assistant, and this has already been vetted by the institution or compliance and legal teams. And that you, instead of posting that real patient note, you can play with this data set. Okay, then if I will say somebody coming with heart failure, diabetes, and then you ask this data set to, draft a note for me. Oh, can you do a discharge summary for me? Or what is the guideline? It's like almost like a AI playground. So I feel like there's a promise for that when you come to, like, when you think about this security, privacy, and confidentiality of patient information. So I feel like it's increasingly happening in industry. I don't think we can take that out because that's the only option for sometimes to develop some new tools.
Thank you very much, Dr. Ranasinghe. Dr. Bovelle, would you like to weigh in on that? Nope, not quite there.
Sure. I just want to mention that we have to realize AI models, they're not like just a simple plug and play. You want to make sure that the AI tool that you choose, it may work in the vendor's environment, but it may underperform in the real world, especially if it's not specifically designed for healthcare. For example, we're all aware of the Epic sepsis model several years ago. It was used in many hospitals and it underperformed when it was actually used in the hospital, and it missed 2/3 of actual sepsis cases. So obviously that's a problem. So what do we want to look for? I'm going to talk about this in more detail, but when evaluating vendors, you want to look at software quality, pressure testing, is there fairness and bias mitigation. We've seen this in other models in medicine. How is the AI data? How is it trained? And you want to look at, is it safe, accuracy, and accurate? We want to look at sensitivity, which is the true positive rate. We want to look at the true negative weight, the positive predictive value. All of these things are important because we want to be able to trust the AI, but we also have to remember, don't just throw your physician knowledge to the AI. Remember, it's a tool. So you have to look at it, use it as a tool, but make your own judgment.
Thank you. But before we move on to a related topic, I just wanted to try to put the question directly, and that is to both of you is, so you've got these tools such as this, the what we're talking about, synthetic data. When does one decide that they can move on to a live situation? So you're training your physicians using this synthetic data on a system which you believe is secure. What is the benchmark for moving that over? And it might be just moving that over to live. And I realize this could just be a rhetorical question because it's still being evaluated and we're still looking at that. But if some of you out there are like me and our panelists, you're starting to see vendors, or you've been seeing AI vendors, healthcare vendors, come to you with products telling you that they're perfectly safe. We've got it all figured out. They're secure. You can these are in the marketplace. You should consider purchasing. And sometimes they use some high pressure tactics to try to get you. So I don't know if either of you want to field that before we move on. Just when do we decide it's safe enough with the risks out there? And we'll talk about the risks more later. But when do you decide to move on? How do you decide to move on? What are the benchmarks?
Well,
It's
Dr.
re-
Wargotz, we
okay.
know we've been through this before, right?
All right.
Can anybody remember EMRs? Oh, it's going to be better than paper.
Right.
Right? So we've been through this. It's going to do everything. It's going to make your life easier. Everything's going to be wonderful in the world of EMRs or EHRs, whatever you want to call it. Right? So we've kind of used to that. So now we know, first of all, you want to make sure that this has been, there should maybe be a physician involved. Maybe a physician who's has been a part of the company or has helped to vet this. You want to talk to your colleagues. Ask for references before you choose the vendor. Don't make sure, like I said, you look at the software. What is the specificity? What is the true negatives, the true positives?
Well, I
Because
know we're going to get to all that later, but in terms of I think
I
the
think.
answer, I hate to
Mhm. Can
answer
I
my
say
own question.
something, Dr.
Yeah,
Vogat? Yes.
yeah,
So
sure.
definitely, this is a really interesting question. When do you like transition? So
Exactly.
this is where actually one physician or one group, small group practice can't handle this. This is where we all need to work together. Right now, industry is dominating. For example, I went to a conference recently through MA, and it's all new tools are done by industry, not much physician involvement. Even if there's a physician involvement, we need to have a system to want to regulate them and to give oversight and everything. And additionally, we need to be careful. These data might be like skewed in one direction, right? It could be for white male or versus like, all these like other issues related to that we need to understand before we implement. What I would say is you have to go through a rigorous process. It might be FDA, it might be another organization. We need to have that system in place, which we don't have.
Thank you, doctors. Let's move on to a related as important subject. So AI is a new attack surface, meaning, it's out there and boom, boom, boom. There's lots that can happen. AI has moved from simple documentation systems that we're all familiar with, scribe systems and such, that proactively, and now some proactively coordinate tasks, review surgical videos for technique, and flag missing details in patient records. Some AI agents, particularly the generative and agentic, as they call them, handle vast amounts of protected health information, PHI, as we mentioned earlier, making them prime targets for double extortion ransomware. AI agents must be treated as critical security perimeters, not just software, as Dr. Bovelle emphasized earlier. And we will continue with Dr. Ranasinghe addressing this first, and then Dr. Bovelle.
Yeah, I think the what is in the slide is extremely accurate, and that's where things are. To highlight some of them, right? AI in healthcare is not about notes anymore, right? It's not just EHR anymore. Now, some of the tools can coordinate tasks across care teams, right? And can even chart and identify missing data or details and let us know as doctors, and then provide decision support on clinical tools or imaging, and then also can at a population where they can like predict the risk in certain group of population, and then also individualized treatment options can be like prompted to us. So which when well designed can actually help us to prevent having a lot of duplicative work And then also, as you know, like the when ambience AI was introduced, how the burnout rate went down because of cut down on after hours chatting. And then also we can focus our biggest as doctors interest is like a doctor patient relationship and clinical judgment. And then in regard to surgery, and then I recently listened to a podcast on how surgical discipline is like moving forward as similar to other medical specialties. And then they actually AI can team help to like a complex care get into like a whole team dynamic, and then standardize this interpretive procedure. There's like a differences in sometimes among surgeons, but if you can standardize, outcome will be a little bit more standardized. And then also thinking about more safety quality related in terms of surgical. But the biggest issue is as soon as this system will get another tool and plug into an EHR or inbox or scheduling or any perioperative platform, they are touching very large amount of data without our knowledge, even our inboxes, whatever that may be, we take care of patients right through that, which makes them the prime target for this modern double extortion or ransomware attacks that we talk about, and then steal data. That's the biggest issue. You just plug in something to any of your computer related, patient related information, or even your inbox. That's the reason I think um, we have to treat all of these tools can read the patient information, can be traced, and then think as not as a casual app, and should be having a security perimeter subject to HIPAA level of protection. We have to think about very strongly this, and some authentication and then also very important to have clear vendor like a contracts. And also if we can log and audit trails can we get from the vendor. Those are like important facts to consider. And then also we need to have a response plan if something happens. What are we going to do if you notice that? Who to contact? What type of other action? How do we get in touch with vendor? And then also need to have a support system, including informing patient, and patient should be part of that discussion too.
Thank you, Dr. Ranasinghe. Dr. Bovelle, what would you like to fill in, or what would you like to say about this issue?
Well, Dr. Ranasinghe covered it very well, but I just want to define what is double extortion ransomware.
Thank you.
It's a type of cyber attack in which the threat actors not only take your sensitive data, they also encrypt it. That's why it's double. They steal it and then they lock it up under key. So even if you can get it back, you can't open it. And that's how they use this to leverage and get large ransom payments. And you may think, well, why would, I'm just a small doc. Why should I pay attention to this? Well, there have been physicians who've had to close their practice because of these ransomware attacks. So it affects the small doctors as well as the large doctors, large healthcare groups. And the problem is we need to recreate our mindset, a mindset, we'll probably talk about this sooner, of cyber hygiene, because we're used to being open. I have to call Dr. Ranasinghe to help me with my patients when I have to send them to Hopkins. She may call me. I have an ophthalmology patient. How am I going to handle this? We're used to being open. And now dealing with cybersecurity and this cyber technology, we have to be closed. So this is the opposite of how we as physicians and in healthcare are used to operating. So that's one reason why we are at a prime target. These cyber attacks affect us much more than even in the financial industry. We're used to keeping our money tight, but we're not used to the other.
So let me ask you both this before we move on to cyber resilience and patient safety, which is all related to this. When you have a system that goes down, what do you do? We're going to get there in a minute. But I want to ask you both, when we get notification uh, from, let's say, in this case, a medical system, and I've had some over the past year, at least one, but I won't mention the medical system, where they notify you that there's been a breach. We know there's been a data breach. We know that your information was included. We're not sure of exactly what information at this point. And maybe they offer you some identity protection or something. But I've had at least one healthcare company or insurance company, or I don't recall exactly, medical system, reach out with that. So they're really talking about this kind of stuff, maybe not the double extortion ransomware, but just that there's been a breach. So we're already seeing, as Dr. Bovelle alluded to, that healthcare information is being tampered with. Well, maybe not tampered with. It has been breached, the systems, and we don't know what's happening with the data obtained by the folks who get it, who break in.
I can tell you what's happening with the data. They're selling
That's
it on the
good.
dark web. That's what they're doing. And they're selling it so they can create a new identity. And it happens with everything. I just saw in the news the other day what's happening with young people getting ready to go to college.
Right. Okay. Well,
They're
thank you.
applying for financial aid, and they find out somebody else has already applied for
Right. So it's
financial
all
aid
related
under
to
them.
identity theft and obtaining
Yes.
money,
Yes.
financial.
And
Yeah.
the thing is, people will pay more for this information than they will for a credit card. Why? Because you find out, okay, your credit card's been stolen, you turn it off, the credit card gives you reimburses you and all of that. That does not happen with this. It could take years
All right.
to get
Well,
your identity back.
thank you for addressing that. That's very helpful to me.
I
Hopefully,
can
other
say one
folks.
thing. Data is
Yes.
currency in this area. That's what the hospitals think their data is so much expensive compared to the others. So any healthcare data is
Well,
an
I don't know about the rest of you, but I'm getting very nervous listening to all this. So we'll just have to see how it evolves, and it's here to stay. And let's move on to how we try to recover from these kind of breaches, because it seems like no matter what we try to do, there's always people who are clever, intelligent out there working on the other side to break in. So let's move on, doctors. And so cyber resilience is patient safety. The term uptime is being replaced by cyber resilience, the ability to recover systems like we used to and still see with EHRs, recover systems within 72 hours of an attack to ensure care continuity. The focus is shifting, if it hasn't already, from staying online to how quickly can we recover. And there are proposed 2026 regulations suggesting a 72-hour rule for restoring critical EHR systems after an attack, and hence moving the conversation from IT problems to clinical risk management. Dr. Bovelle, I'd like to switch things up and have you respond and give us your thoughts and expertise on this, and then followed by Dr. Ranasinghe.
Sure. Well, as you mentioned, cyber resilience is the ability to understand the organization's capacity to anticipate, maybe that's prevention, withstand, recover, and adapt from any kind of adverse cyber event, not just an attack, but any adverse event. And we need to, as healthcare workers, we need to do this because we need to continue our work despite breaches, because we saw it can result in increase in morbidity and mortality, even death. So we have to, as I said, change our idea. We have to move to cyber hygiene. And I kind of alluded to this. Healthcare pays the highest price of any of the critical infrastructure sectors for cyber attacks. So that's why we have to have this cyber resilience. In 2025, it cost $10.2 million of healthcare cyber attacks. The average cost per healthcare data breach reached that high, 10.2 million.
Wow.
In 2025, it costs $400 per record. So let's say you have 10,000 records, but many, even private practice, have way more than 10,000 records. Do you have an extra $400,000, $500,000 laying around to recover? That's about how much it's going to cost you to recover. Then you may have to pay fines on top of that, but that's another thing. So
Well,
healthcare data breaches exposed over 275 million records in 2024. You were going to say something, Dr. Wargotz.
I'll save it for both of you after Dr. Ranasinghe.
Okay, so that's 82% of the U.S. population. So like you said, Doc, you get these emails, your data has been exposed. I receive them all the time, and it almost becomes like alarm fatigue. We don't even pay attention to it. What do we do? So we have to have buy-in from the physician leader and from the C-suite. This includes solo practices to large hospital systems. We have to have this cyber hygiene. We're taught wash our hands from the time we enter med school. We're taught this. Be clean. Clean the patient before you operate, before you even touch the patient. So we have to do the same thing. And how do we do this? We have to understand that cybersecurity is different and distinct from IT. Just because your son's neighbor's cousin can hook up a computer, that does not mean they're a cyber expert. Just as, for example, neurology is a distinct specialty from neurosurgery. They're interdependent, but they're different. You need both. So
excellent point. Excellent point.
Yes, I want people to really get that. And if you think about it, this also involves in how do you choose an AI vendor?
Well, we'll get to that. So,
okay.
yes, as you know, but wonder if Dr. Ranasinghe would like to weigh in on the cyber resilience.
Mine is quite short because Dr. Bovelle has an expertise in this area. I don't try to pretend whatsoever. One thing I would say though, this is a global threat, right? Every time you turn on anything, I mean, regardless of PHI or anything, that is can access by anyone around the world. And then second thing I would say, with the trend that we see here, we need to incorporate this at the medical school level. Medical
Yes.
students should be aware, as well as residents. At this point, the curricular involvement of this AI, cybersecurity is really minimal. I would say there should be a push on we learn these things quite early. Because every time you learn something related to cybersecurity, then there must be a newer technique of doing that. So hopefully AI can fix some of them, also trying to identify some of them, but at the same time, that's like a double whammy. AI is the one doing all this new technique. That's all I would say at this for
Well,
this.
Doctors Bovelle and Renasinghe, it seems to me that looking at the proposed regulations suggesting a 72-hour rule, I'm neither here nor there. I don't know if that's reasonable or not. I'm wondering if just briefly, a couple of sentences, each of you, because I have to keep an eye on the clock, but I think all of us would be interested in your expert thoughts, both of you, on is that reasonable
It
for that?
can be if you follow a couple of things. I just want to briefly go over. How can you help to make sure you can keep in touch with the 72-hour rule? One, keep your systems up to date. Backup files, secure the backups offline, use reputable antivirus software, personalize your anti-spam, educate, we talked about that, patch, have privileged account management based on roles. Clinical employees don't need access to billing and vice versa. Perform a risk assessment. That's most important. Review all IT infrastructure to identify potential vulnerabilities. Don't just use a checklist. Get your cybersecurity expert, just like you have a taxes. If most of us don't do our own taxes, we get a tax professional to do it. Get a cybersecurity expert to help you. Do vulnerability assessments. They're going to show you where all the holes are in your system and how to protect it.
Thank you. Dr. Ranasinghe?
Only thing I would say is like you need to have a system in place when you first accept this kind of a new tool so that you know what interventions you should be doing if you notice some of them so that you are not following that after an attack. That's where I think we need to think about at the state level, federal level, who is going to help us in this one.
Okay, well, that's interesting because I guess there's one follow-up question I'd like to ask. It's similar to one I had for later, but I think we'll cover it now. One of our attendees is sort of asked similar to what we were going to cover a little later, and that's other than not opening an attachment or clicking on a link, what are some of the other techniques you would suggest to physicians to prevent creating a portal for a potential portal for a cyber attack by opening or viewing an email or even a text? Because as you know, it's very sophisticated, and your spam and junk text filters don't always work perfectly, right? We know they don't work perfectly. So again, I wonder if each of you could take a crack at that.
Well, that's where having the vulnerability assessment comes in. And I would have that every single time you add a new device to your system. And that's going to help to close the portals or close the doors.
Thank you. That's great. Dr. Ranasinghe, do you have anything to say?
Only
Or
thing
we'll
I
just
would
move
say,
on.
because I work at Hopkins, every time we have this kind of thing, they take care of that. If you have somebody else doing that,
Right.
that always be help. Okay.
Okay. Very good. Well, let's move on to the 2026 current regulatory landscape. So, as many of you are aware, and I know our panelists are, there's been a patchwork of new state laws. California, AB 489, now regulates AI transparency and bot disclosure. MedChi passed legislation protecting insurance company use of AI, meaning, really protecting the consumer from the insurance use of AI. And currently federal AI guardrails remain limited, leading individual states like California and Texas to pass their own, as mentioned earlier, AI transparency laws such as mandatory disclosure when AI is used in diagnosis, highlighting the shift towards explainability behind AI decisions. So, Dr. Ranasinghe, you've been very much involved in the AI leadership, as is Dr. Bovelle, but let's lead off with you and your activities as immediate past president of MedChi, dealing with this, as well as your leadership role at AMA and at the state level now.
Yeah, I have a lot to say on this one, but I'll try to summarize some of them. As you know, as of 2026, we are seeing a real patchwork of AI regulation across the country. The main reason the federal regulation remains still very limited. So states are trying to step in more than actually, if you know, 250 bills were introduced in 2025 alone. Now we have laws on the books in California, Texas, Maryland, Illinois, Utah, and others. I'm going to mention like 3 bills. So for California, there's a bill say AI chatbots can't pretend to be doctors, and patients must be told when AI chatbots are used interacting with the patient. And Texas has another bill now mandate that physicians tell patients when AI is used for diagnosis, treatment, and also need to mention human oversight of generated records. So this is a very controversial topic among doctors. So, right, some doctors say every time I have a using AI tool, how should I tell the patient? However, it is a law in Texas now. And in Maryland, MedChi actually was active last year. We supported a legislation to make sure that insurers can't use AI as a black box. any AI used in utilization review has to consider the individual patient, not as like a population level data, and also cannot replace physician judgment and must be regularly reviewed for accuracy and transparency. That's the Maryland law. So, what all these signals is a major shift towards explainability, right? We know that the ideas that clinicians and patients have a right to know when AI is in the loop and how it is being used. And critically, the physician must be able to understand, question, and override the recommendations rather than practice inside this black box. So actually, in our council at the MA now I'm chair, we wrote a report about AI explainability, and then the essentially showing this black box. But we as doctors need the importance of like understanding what is happening inside this black box, so that we keep this doctor-patient relationship and trust. Explainability has become somewhat important in building trust with the patient.
Well,
And
thank
then
you, Dr.
also,
Radisson. I wonder if
okay, go ahead.
both you and Dr. Bovelle will move on to we'll talk about the AMA and MedChi. They've both been, we all have been deeply engaged in the fast-moving world of AI in healthcare, and with a clear focus on making sure physicians stay in control of clinical decision-making while leveraging the real benefits these tools can offer. Here in Maryland, MedChi has been active in the same space, weighing in with state leaders, tracking regulatory proposals, and making sure any AI adoption in our hospitals, practices, and state programs support physicians rather than replace them. And both organizations are committed to an approach that embraces innovation but keeps the physician-patient relationship at the center. And so I wonder if you would continue on that, and then we'll hear from Dr. Bovelle on her thoughts in the relation of cybersecurity in these efforts. So please continue, Dr. Ranasinghe. Dr. Ranasinghe, please
She's
continue.
Oh,
on
yeah, no,
mute.
no, I was muted. So as I was telling about the state, what the we need to know what the federal government is doing at the same time is they are trying to take away all this regulation to the federal level, thinking that having a 50 state mesas for AI is going to confuse everyone. So ultimately, it's really affecting physicians to choose from federal government policies versus state regulation. It's going to be a little bit an issue for practice in medicine. I would say in MedChi, we are actually partnering with leaders and also monitoring all these regulatory process. And our goal is to support physicians and care teams rather than replace physicians. That's our model, right? We need physicians to be on the table and to be like on the as a human in the loop for AI. And then also I need to quick plug into this. CME session is February 11th at 6:30. We are focusing on AI in radiology. If you can join, that would be great. And then you probably can see on our website. And then at the national level, AMA actually is trying to take a leadership at that for all the specialties. And they just created a center for digital health. And then the main focus is to physicians should be at the center for all these AI tools. And it has 4 pillars. I'm going to read them. It's mostly policy and regulation and how to integrate into workflows. And then it's really important education and training current physicians and physician in pipeline. And also need to collaborate with healthcare, technology, insurers, government, and industry. And at the end of the day, what we are trying to achieve is safely, responsibly adopted AI that help physicians rather than creating another burden.
Well, thank you. That's a nice comprehensive review of what's going on in the regulatory environment that you're involved in and MedChi is involved in. Dr. Bovelle, please, we'd like to hear from you on how you view the regulatory environment and how it certainly is addressing or not addressing cybersecurity concerns.
Sure. Well, what I'd like to say, it's very important to be involved in organized medicine. Why? Because organized medicine works for you. It's going to protect you whether you're a solo practice or in a healthcare. How? For example, MedChi has been monitoring the use of insurances using AI to prevent paying us in billing denials, things like that. So that's one way MedChi has been helpful. Another way is with cyber insurance. What is cyber insurance? Well, when you have a cyber attack, your insurance company will hold your hand and walk you through it. Here in Maryland, we're lucky enough to have access to Unity Insurance. It's a MedChi company. So what does cyber insurance do? It helps you with the data breach response, covers legal fees, forensic investigations. That's kind of, I alluded to that. Notifications to inform patients, has business interruption coverage. They also provide regulatory compliance, help to pay the fines, legal defense. You will need legal defense, and ransomware and cyber extortion coverage. You wonder how people get by with the 72-hour rule. Sometimes people pay. They don't talk about it. Steps to future-proof your practice, employee training, incident response. Let me just say this. Why is it important to have cyber insurance? Because going through these digital forensics, it may show that you had a cyber attack, but your information was not breached. So maybe you don't have to go through and pay all this information. That's what doing digital forensics does. And then
Okay, but let me bring you back to the regulatory environment, if I may. I know you're going to wrap up and talk more about cybersecurity in a little bit, but just in terms of the regulatory environment, what are you seeing? Are we moving? I guess we can never move fast enough along, but in terms of cybersecurity, is the cart getting before the horse? Has it always been that way with AI?
It's been that way with cyber, because remember, the criminals don't have rules. They don't have regulation. So we're always behind.
Okay, well, thank you. That's
Can I
excellent.
add something? I
Yes.
feel like right now we are in a time that federal government is trying to deregulate most of this, in thinking that innovation is more important. So that also might have been creating an increased threat in cybersecurity area.
Well, thank you both very much. It's a fascinating discussion. I'm sure our listeners, our attendees feel the same way. We're trying to cover a very broad swath of material on two very important cutting edge subjects in a very brief amount of time, 1 hour. And you're doing an excellent job. I can't thank you enough. But this is my job as moderator, keep an eye on the time, and we are quickly running out of it. So what I'd like to move on to is our closing comments. And I know you all have prepared some points. And so Dr. Bovelle, please lead us off. And thank you once again for joining us today.
Sure, very quickly. Any one of these topics could be, a whole hour. But understand the culture of cyber resilience. I didn't get a chance to really go over how and why to choose a cybersecurity vendor. You want to make sure that they have what you need. For example, for me in ophthalmology, I want to make sure I have a vendor that uses tools that are device agnostic. Maybe some vendors say you have to use, like Zeiss may say you have to use my products. Topcon may say it's agnostic. You don't have to do that. So that's what you want to look at. Minimum use roles, that helps to close some of the holes. Someone asked how you can close the holes. Minimum use. Everybody doesn't need access to everything. And lastly, cyber insurance. Why? Because they're going to make sure that you have your compliance program, you have your digital forensics, everything else. Briefly, that's it.
Oh, thank you. Thank you, Dr. Bovelle. Dr. Ranasinghe.
Yeah, very briefly. I want to highlight the fact that we as physicians have some role or important role in engaging with development of this AI tool from the time the idea to adoption to evaluation and implementation. It's really important. I can't stress that enough, because if we don't be on the table of all this development, they come up with solutions and then it's like similar to previous EHR or even scope of practice issues. We are kind of behind. And then next thing I would say, AMA has been doing a survey like every year for last many years among physicians to see how they use AI and what they use for. And then they have found last year the usage of AI has doubled from 23 to 24, from 38% to 66%. And then most recent survey shows there's no age or gender difference in terms of the use of AI tool, which is also interesting. And then the things that they use mostly for administrative burden and documentation. And then that's the most important thing they use for based on the survey. And the third thing I would highlight is importance of education, right? We as doctors, sometimes I feel like a little bit monolithic and then tentative, because we can't 100% say patient get better or worse. So, but on the other hand, computers, AI is trying to be certain that kind of, analyze large amount of data and give an answer. So we need to learn, upskill these skills, some of them. So there are a lot of resources available in all those, I think, medical societies. What I know is AMA has EdHub, has CMEs free of charge, and you can actually learn. And then again, I said MedChi is doing a CME course or CME session. So next one is February 11 on AI in radiology. Please join. And then also, I think everyone else mentioned previously, it's important that organized medicine, either the specialty society or MedChi or AMA, had to be on the table in terms of regulation governance. Sometimes I feel like in state level, MedChi should be the one actually giving instruction which tool to use for private practices or institutions. So I don't know if we are going to go that level. At least I think it's important that organized medicine to be alive. And then if you're not a MedChi member, please do so, and then be engaged in any of the societies. And especially in this climate, we have to do that actively.
Well, thank you very much, both of you. I'd like to, first of all, give a mental round of applause and thank you, a hearty thank you to Dr. Renee Bovelle and Dr. Padmini Ranasinghe for sharing their time with us today, sharing their expertise out of where many of us many who are attending, listening in, are physicians, and thank you for taking time out of your day. Uh, this is a series of lunchtime webinars that we present, which I moderate. The next one is scheduled for May 22nd at noon. Get it on your calendar, topic to be announced. Also want to recognize, of course, our CEO, Gene Ransom, for handling things behind the scenes and assisting us here, as well as his assistant, his executive assistant, Barbara Fitzgerald, for her help in organizing this. I want to thank all of you for joining us. Please continue to join us. I try to select topics that are cutting edge in our healthcare environment today. And that they're difficult, they're broad, it's tough to get into an hour, but we're trying to at least introduce you to some of the critical issues facing healthcare today. So this is Eric Wargotz, President of MedChi, your moderator, signing off and thanking you all very, very much for joining us. And please don't hesitate to join us again. We love to have you. Bye-bye.